One injured nerve can make standing from a chair, climbing stairs, and even walking a challenge. Today, we are uncovering the anatomy behind femoral nerve injuries. Hello everyone, I'm Dr. Divya Dasa and welcome to ACE Anatomy, where anatomy becomes simple, visual, and clinically relevant. In today's Anatomy in Practice, we will learn how to identify and localize femoral nerve injuries by understanding the anatomy behind the clinical signs. So let's get started. First, recall the key features of femoral nerve. We know that it's the largest branch of lumbar plexus, arises from the posterior divisions of the L2 to L4 ventral rami within the psoas major muscle, has a root value of L2, L3 and L4 and is the nerve of the anterior compartment of thigh. Let's now quickly go through the course of the femoral nerve. So the femoral nerve, once it begins from the lumbar plexus within the psoas major muscle, it runs within the substance of the psoas major, emerges on its lateral border, passes between psoas and iliacus, and then runs behind the inguinal ligament to enter the thigh. So in the thigh it lies lateral to the femoral sheath and it runs for about 2.5 centimeters where it divides into its anterior and posterior divisions. So that is about 2.5 centimeter below the inguinal ligament, and both these divisions, they will be enclosing this lateral circumflex femoral artery. The anterior division is mainly cutaneous and the only muscle it supplies is the sartorius. The posterior division is mainly motor, supplies the extensors of the knee joint, all the quadriceps femoris muscle, as well as it also supplies knee joint as well as the hip joint, and it continues as the saphenous nerve which supplies the skin on the medial side of the leg, medial side of the foot up to the ball of the great toe. That is briefly about the course of femoral nerve. Let's look at the injuries of femoral nerve. The femoral nerve is rare, but it may be injured by stab wounds or gunshot wounds or pelvic fractures. So what happens because of the injury to the femoral nerve? Injury to the femoral nerve results in both motor loss as well as sensory loss. Now in the motor loss, we see weak flexion of the thigh. This is because of paralysis of iliacus and sartorius muscle. Then there is inability to extend the knee. This is because of the paralysis of quadriceps femoris muscle. The sensory loss we see mainly on the anterior and medial aspect of the thigh because of the involvement of intermediate and medial cutaneous nerves of the thigh. We also see the sensory loss along the medial side of leg as well as the medial side of foot up to the ball of great toe because of the involvement of saphenous nerve. Normally, the main trunk of the femoral nerve is not a subject to an entrapment neuropathy, but it may be compressed by the retroperitoneal tumors, or a localized neuropathy of the femoral nerve may occur in diabetes mellitus. Now, because of the compression, there is wasting and weakness of the quadriceps muscle leading to considerable difficulty in walking. There is also pain and paresthesia on the anterior and medial aspects of the thigh, which will extend down along the medial aspect of the leg and the foot, that is, along the distribution of saphenous nerve. And that brings us to the end of today's episode of Anatomy in Practice. I hope this video has helped you understand not just the different femoral nerve injuries, but the anatomical basis behind each clinical presentation. Remember, clinical anatomy is easiest when you understand the why, not just the what. If you found this video helpful, please like, share and subscribe to ACE Anatomy, and don't forget to turn on notifications for more simple, visual and clinically relevant anatomy videos. So if you have any questions or suggestions for future episodes, leave them in the comment below. Thank you for watching. I am Dr. Divya Desa signing off. Keep thinking clinically and keep acing your anatomy.